Welcome back again, everybody. It is the CCFP 105 Topics podcast from the Generalist. We are talking vaginal bleeding. This is part 2, covering the non-pregnant patient with vaginal bleeding. It's still me, and it's still Aikansha. She's still crushing it. We're going to tie this one up with you today. Get your earballs on, chill out, grab something nice, a comfy seat, a comfy bike ride, whatever you're doing. We're happy you're here. Objective 2. In a non-pregnant patient with vaginal bleeding, do an appropriate workup and testing to diagnose worrisome causes using an age-appropriate approach.
We can use the mnemonic PALM to help us work through our differential diagnosis for abnormal uterine bleeding.
Everyone knows this one. We're just reviewing here. So PALM, this is the structural causes. Your hand is a structure. Maybe that helps you remember it. So you're thinking of things like P for polyps, A for adenomyosis, which is where it invades into the myometrium. Leiomyomas is the L, or fibroids, but it fits the mnemonic better this way. And malignancy or uterine hyperplasia is the M.
Polyps in the uterus are often asymptomatic, however, can at times cause irregular menstrual bleeding.
Adenomyosis is benign growth of endometrial tissue into the myometrial layer of the uterus.
Although some patients may be asymptomatic, others experience abnormal uterine bleeding, dysmenorrhea, and chronic pelvic pain.
And you might notice a soft, boggy uterus on exam that's a little bit tender to palpation, and that might flag you a little bit to get an ultrasound and figure it out.
Fibroids, also known as leiomyomas, are benign growth of smooth muscle within the uterus.
Some common symptoms of leiomyomas are abnormal uterine bleeding. This is often seen as heavy, painful periods, and maybe it's changed over time and you don't know why. It's important to note they generally aren't going to cause irregular bleeding. It'll just be more pronounced cycles.
Fibroids can also present with pelvic pressure.
And you can get obstructive symptoms, so urinary frequency, urinary urgency, but it's not looking like a UTI. That could happen if the leiomyoma is large and obstructing the bladder.
If the fibroid is large and proximal to the bowels, you can also get bowel dysfunction.
And they might have a history of infertility as well as a result of having the fibroid but not having these other symptoms.
On physical exam, you may notice an enlarged mobile uterus with irregular contours.
Yeah, I don't know how good my palpation skills are for that. Let's talk endometrial hyperplasia and endometrial cancer. That's the M in our PALM.
Risk factors for endometrial cancer can be assessed on history and physical exam and include
age. Older folks are more likely to have cancers.
BMI greater than 30.
Nulliparity.
Chronic anovulation.
PCOS.
Diabetes.
Oh boy. Hereditary non-polyposis colorectal cancer, HPNCC. It's a genetic condition that increases somebody's risk of endometrial, colon, and several other cancers.
And then another risk factor is tamoxifen use.
Nice. All right, we did PALM. Remember PALM. If you need to listen again to PALM, listen to PALM. Now we're going to talk coin.
This side of the mnemonic considers medical disturbances that could cause abnormal uterine bleeding.
So think of coagulopathies. That's the C part.
Von Willebrand disease is the most common inherited bleeding disorder, accounting for around 70% of abnormal uterine bleeding secondary to coagulopathies. That's a big number.
Yeah, it's surprising. I don't remember maybe I should start testing for this more. Some less common disorders are things like factor 11, 7, and 13 coagulopathies, carrier status for hemophilia A and B, and other inherited disorders of platelet dysfunction.
Patients with coagulopathies as the cause of their bleeding often report heavy, regular cyclic menses without intramenstrual bleeding.
And then in adolescence, they might have heavy menstrual bleeding starting at menarche, so they didn't know they had this, but then you've got this organ that needs to bleed and you notice it bleeds more than it should.
Patients may also report easy bruising, frequent nosebleeds, and prolonged bleeding with minor injuries or following dental procedures.
And it might just be a family history of bleed disorders that gets your radar up to go looking.
If you're suspicious of this, referral to hematology should be made for a definitive diagnosis.
No hesitance here. So C was for coagulopathies. We're going to talk O for ovulatory dysfunction. This is patients with ovulatory dysfunction. They're often going to present with irregular or unpredictable bleeding.
Causes for ovulatory dysfunction include PCOS, hyperthyroidism, hyperprolactinemia, anorexia, mental stress, and excessive exercise.
If your patient with this irregular bleeding has signs of hirsutism, so hairy lip, hairy arms, hairy back, lots of acne that you wouldn't expect, alopecia, if they have a history of infertility or irregular menses, then you might want to start ordering FSH, LH, and an ultrasound looking for enlarged or polycystic ovaries so you can help them get a diagnosis.
If your patient is showing signs of hypothyroidism, consider ordering thyroid function tests.
If they have galactorrhea, so they're making milk when they wouldn't be making milk. If they've got impaired renal function. If they're taking meds like estrogens, antipsychotics, or SSRIs, think of hyperprolactinemia.
Ovulatory dysfunction can also occur when the body experiences extreme stress. So this can occur in patients with anorexia, excessive mental stress, or with extreme exercise.
And then finally, abnormal bleeding in adolescence is commonly caused by ovulatory dysfunction due to immaturity of the hypothalamic pituitary ovarian axis. This is super common, and sometimes you just have to let them know that it can be weird and wonderful for a little while, and then it'll settle into a nice cycle. Or if not, then we'll look into it.
The E in our mnemonics refers to primary disorders of the endometrium.
Often, this is diagnosis of exclusion for patients who are having heavy bleeding during regular and predictable menstrual cycles.
This diagnosis can only be made when other causes have been ruled out.
I is iatrogenic. It includes breakthrough bleeding for patients who use hormonal therapies and abnormal bleeding with hormonal or copper intrauterine devices.
And then finally, the N stands for not yet classified, such as chronic uterine inflammation, such as chlamydia, pelvic inflammatory disease, foreign body, and AV malformations.
The weird and wonderful. All right, but there's other things besides the uterus. So think of non-uterine causes of vaginal bleeding.
This includes cervical dysplasia, lesions, or inflammation, such as secondary to infection.
Genital lesions or cervical polyps.
Vaginal laceration, so ensure you do a speculum exam and inquire about recent trauma.
And think of alternative sources of bleeding: perianal, rectal, urinary tract bleeding.
Now knowing what we would include on our differential, we can now review appropriate history, physical, and investigations to order.
Whew. History. You need to do a general history for all patients with vaginal bleeding, not just about the uterus, but all over.
This will look similar to the history that we discussed in Objective 2 and should include characteristics of bleeding, menstrual history, including signs and symptoms of menopause if appropriate, associated symptoms, sexual and reproductive history, obstetric history, gynecologic history, past medical history, and medications.
And all in a 10-minute family practice visit. Screen for symptoms of hypothyroidism, hyperprolactinemia, coag disorders, PCOS, adrenal or hypothalamic disorders. These can all be systemic causes, as we talked about before, of abnormal uterine bleeding.
You're also going to want to do a physical examination, so this would start with an assessment of vitals.
Do a belly exam. You're looking for masses or signs of peritonitis.
You'll also want to do a gynecological exam, which includes assessment of the vulva, vagina, cervix, via speculum exam, anus, and urethra.
Do a bimanual exam to assess the uterus and adnexal structures. I just do bedside ultrasound now. I don't know. But yes, for the exam, do a bimanual.
You're also going to want to do a rectal exam, including a DRE, if you're considering that the bleeding may be coming from the rectum.
And then for completion's sake, think of all the other parts of a physical.
So this includes weight and calculating the BMI.
Feel the thyroid gland and look for signs of hypothyroid.
Assess the skin to look for changes such as pallor, bruising, striae, or hirsutism.
Love it. The nice thing is once you've done your history, you're also already funneling down some of these for palm versus coin. So you're not asking everything and you're not examining everything, and you have your suspicions of a smaller differential. You're going to get potentially a CBC, TSH, swabs for gonorrhea, chlamydia, pap test if they haven't had it recently, and a transvaginal ultrasound for everyone.
You're going to consider an INR for heavy bleeding, talk about those coagulopathies.
You might get a prolactin level, LH, FSH, or estradiol if they're oligomenorrheic.
And then plus or minus an endometrial biopsy.
Part B, diagnose and treat hemodynamic instability.
Acute resuscitation measures should be made to manage hemodynamic instability in non-pregnant patients. Patients should be referred to the emergency department for this care.
So this is starting a movie, IV fluids, blood transfusion if their hemoglobin is dropping or if they're actively bleeding a lot, bedside ultrasound looking for anatomic causes or free fluid to see if you need a surgeon quick, and blood work to assess for anemia and DIC.
Medical management for unstable non-pregnant patients can include IV or PO estrogen, noting that nausea is a common side effect of high-dose estrogen, so currently giving an antiemetic like ondansetron, as well as TXA.
This comes up a lot, and it's going to happen in the clinic a lot, and you probably should get comfortable with prescribing TXA like 1 gram 3 times a day until they're resolved, and having second and third line options in your back pocket. An acute episode of bleeding, once it's resolved, they can continue to do their daily OCPs or TXA until they get the further workup.
Some contraindications to high-dose estrogens and TXA can include acute PE or DVT, inherited thrombophilias, recent MI or stroke, or an active malignancy.
There's controversy around that, and a lot of people would say it doesn't cause DVTs and VTEs, but we'll leave that alone.
For another episode.
When should we do surgery?
Surgery should be considered only when there are known contraindications to medical treatment or if medical treatment fails.
Part C, manage hemodynamically stable but significant vaginal bleeding.
Once endometrial cancer is ruled out, medical management with both non-hormonal and hormonal treatment options should be the first line of therapy. Additionally, treatment for underlying medical conditions such as hypothyroidism should be provided prior to use of non-hormonal and hormonal treatment.
Okay, if they don't want hormones, which a lot of people don't want, then you can think of non-hormonal stuff. They can be used monthly during menses to reduce blood loss, and they're more effective in treating heavy bleeding that is regular and predictable. So menorrhagia, or whatever phrase we're using that I'm not up to date on.
These non-hormonal options can include NSAIDs and antifibrinolytics such as TXA. It's important to note that NSAIDs affect platelet function, so therefore are contraindicated in patients with bleeding disorders.
What if either those weren't working, or they're happy to go the hormonal route first up? Then some hormonal treatment options you might consider.
In general, hormone treatment options are helpful for both patients with predictable cyclic heavy menstrual bleeding and irregular or prolonged bleeding, as it does help to regulate cycles and lighten bleeding.
Some first-line stuff to think are oral contraceptives, depomedroxyprogesterone, so the injectable Q3 month version, intrauterine systems such as Mirena. These are great for patients who want a method of contraception and are also okay for hormones.
Danazol and GnRH agonists can also be used to treat heavy menstrual bleeding if there are contraindications to oral contraceptives, shots, or IUDs. These often require a referral to gynecology.
And then surgically, which is not my world, but it can be considered when
there's a failed response to medical therapy,
when there's side effects or contraindications to the medical therapy,
significant anemia or hemodynamic instability,
and if there's concern or confirmed concomitant uterine pathology, so significantly enlarged fibroids, for example, or uterine hyperplasia that we're worried is contributing significantly.
So obviously at this time, this is when a referral to gynecology should be made, and it's important to have the conversation with your patient around desires for future pregnancies, as this can influence surgical management.
Objective 3. In a postmenopausal woman with vaginal bleeding, investigate new or changed vaginal bleeding in a timely manner.
So, endometrial cancer must be ruled out in all postmenopausal patients with new vaginal bleeding.
Complete and thorough history and physical, abdo exam, speculum exam, bimanual exam. You need to do this.
Initial investigations for suspected endometrial cancer can include both the transvaginal and endometrial biopsy.
On transvaginal, ACOG states that transvaginal ultrasound is sufficient for initial evaluation of postmenopausal bleeding if the ultrasound shows a clear and thin endometrial lining that's less than or equal to 4 millimeters, given that endometrial thickness of 4 millimeters or less has a better than 99% negative predictive value for endometrial cancer. Who knew? Lots of people knew, just not me.
If the transvaginal ultrasound images are not clear, or if there's recurrent or ongoing postmenopausal bleeding, that's when it's necessary to proceed with an endometrial biopsy.
Abnormal findings on endometrial biopsy, like endometrial carcinoma or atypical endometrial hyperplasia, warrant a referral to gynae. Or if you're someone like me who hasn't done an endometrial biopsy in about 4 years, probably they would be your first bet just to get that done in the first place.
And CT scans in general are not recommended for a diagnosis of endometrial cancer.
They should also get a pap smear done if you can, or if you're in BC where we're doing the self swabs for HPV, that's an option as well. Ensure that your patient's up to date on their paps for cervical cancer screening. All asymptomatic patients who have ever been sexually active should have them done every 3 years. They can stop at 70 if their last 3 were negative.
It's important to note that pap smears are screening tests and therefore not indicated for diagnosis in symptomatic patients.
And if there's abnormal findings on cervical assessment or high suspicion for cervical pathology, colposcopy and cervical biopsy might be indicated, and a referral to our awesome, wonderful gynecology colleagues.
And one last thing to note, vulvovaginal atrophy is one of the most common causes of postmenopausal bleeding.
Yes. Do give vaginal estrogen, for goodness sakes, for recurrent UTIs, for vaginal pain. It's magic. It's caused by lower systemic levels of estrogen, which can lead to atrophy of the mucosa after the onset of menopause. It's up to 50% of females within 3 years of menopause. Give them some relief.
In terms of relief, this can be treated with routine application of topical estrogen creams, suppositories, or vaginal rings, as well as encouraging lubrication during sexual intercourse.
Aikansha, this was exhausting. It was a lot of stuff for one subject, but we're very thankful to Alexzandra for making this happen. We're very thankful to Dr. Alex Murphy for reviewing this and giving insight on this topic. It's a tough one. A lot of this we can handle in the clinic and at least get them set up for success and avoid too early or too late referrals to gynecology. Get the workup completed and hopefully make people happier.
Yeah. Thank you so much for having me, Caleb.
You're the best. You're welcome at any time. And in fact, you'll hear her back for the vaginitis episode as well, and hopefully for the foreseeable future. Bye, everybody.
Take care.